Okay, good afternoon, everyone. It's 5 minutes past the hour, so I think we should get started in the interest of time, and other people can join when they log on. So it's my pleasure today to welcome our guest speaker, Dr. Daniel Burns. So he might be known to many of us in the division already. So Dr. Burns completed his medical degree and residency at the University of Western Ontario. He holds a master's degree in epidemiology from the University of Cambridge, and following advanced fellowship training in complex mitral valve repair at the Bristol Heart Institute, as well as the robotic and minimally invasive surgery program at Cleveland Clinic. He was promoted to the Cleveland Clinic surgical staff in 2019, and in June of 2020, he was appointed assistant professor of surgery at the Cleveland Clinic at Case Western Reserve University. And during his Cleveland Clinic tenure, Dr. Burns was recognized as a national leader in mitral valve surgery by the Mitral Foundation and American Heart Association as part of the Mitral Valve Repair Reference Center Award Program. He also developed considerable expertise in the management of aortic disease, multivalvular endocarditis, and reoperative cardiac surgery. And after 6 years at the Cleveland Clinic, Dr. Burns we are lucky to have Dr. Burns coming back to Canada, University of Toronto, joining the Terence Donnelly Heart Center here in June of 2024. In addition to his clinical work, he's also an active clinical researcher with numerous publications looking at clinical outcomes in mitral valve, aortic, and heart failure patients. He also recently completed a 3-year term as the associate statistical editor for the Journal of Thoracic and Cardiovascular Surgery, and is also an associate editor for Innovations, Technology and Techniques in Cardiothoracic and Vascular Surgery. And today he will be talking to us about getting aggressive with aortic and valvular disease, why, when, and how. Thank you, Dr. Burns.
All right, so welcome everyone, and thank you so much for having me. We're going to talk, I think, about a couple of common scenarios that sometimes present somewhat uncommonly, if that makes sense, and talk about when to really push for that higher level management strategy, let's say. So as you can see with the head picture that we're leading with, sometimes things are pretty nasty, and you really have to think about what's coming afterwards. So all right, here we go. So I want to have a case-based discussion. I want to discuss some more advanced surgical strategies for aortic as well as valvular disease. I want to look at evidence and guidelines surrounding these and the decision-making process, and also to explore directions for future study, especially for type A dissection. So my disclosures, I have no commercial conflicts of interest, but I have to disclose that I am a surgeon. So this is going to be a little more surgically minded, but I think it helps the broader kind of heart team community looking at a lot of these issues, especially in some cases of, when to refer, when to get us involved, and when to really, when to think about and advocate for perhaps a more advanced strategy. So I want to start with one case that's right in my wheelhouse, which is a case of degenerative mitral valve disease. So this video should start on, there we go, should start on its own. This is a pretty, again, most of this is a pretty typical presentation. There's severe anteriorly directed MR. There is a posterior leaflet prolapse / partial flail. The odd part in this is that you'll notice there's not a horrible amount, but a reasonable amount of annular calcium. And this patient's actually a fairly younger patient without too much in the way of concerning comorbidity. So the big question is, how are we going to address this? So with a posterior flail, MAC, severe MR, kind of the big three questions I'm always thinking of are, do we repair or replace? Can this be repaired? Or should this be repaired even? So like anything, it's a good place to start with the guidelines here. And these are from the most recent AHA valve-related guidelines. And it's pretty clear, symptomatic patients, severe MR, mitral intervention, regardless. And if it's indicated, repair is recommended in preference to replacement if when the anatomic cause is degenerative disease. Now, obviously, this is nuanced, but immediately we want to think, or when we're thinking, should we repair this valve? Already we're thinking, yeah, we should if we can. And remember, in patients with severe MR where it's limited to, more limited prolapse, we really don't want to replace unless we're forced. So broadly speaking, the way I kind of think about it as well is if a valve looks like this, or like this, we really have to be thinking repair, repair, repair. Now, the evidence in this, there's not going to be any mitral repair versus replacement, trials anytime soon, but we've got a lot of really good quality observational evidence to this for years and years and years. So looking, at this large registry that was published in 2017, pretty clear that looking at survival in all of these cohorts is much, much better in mitral valve repair out to 20 years. And even, as far as how these repairs hold up, we don't even have to look that far. We just have to look down the street to similar results saying that, the likelihood of these deteriorating with a really good repair is actually pretty low. So people with severe MR out to that 15, 20 plus years, we're looking at less than 1%, reoperation of less than 5%. These are pretty good. So not only do these things last if you can get them right, but we expect that the patient is going to do better regardless across the board if they have a valve repair. Now, in this one, how much MAC is too much MAC? Because sometimes you can get around it and sometimes it's a bit of a fool's errand. So, a valve, again, kind of looking like this, where you see extensive involvement of not only the posterior leaflet, but actually back past sort of the annular plane, then we're probably not going to be terribly successful with a reconstructive strategy here. There's just not that much posterior leaflet left to work with. However, and also if you end up pulling out rocks like this, or if you end up having to patch a major defect, this is actually using the anterior leaflet transposed into the defect that we've created with the MAC debridement, you're really not going to be able to repair this valve. But this wasn't how bad this patient was. So let's look at what this patient actually had. So what we see here is looking at the CT, which is the CT here has been rotated and 3D arranged so that this is the same kind of on-face view. That MAC is actually fairly limited, and unfortunately, a contrast CT wasn't done. But this MAC is something that we can usually address. It's actually confined really to the junction of the posterior leaflet and the annulus, and a lot of it is actually subvalvular. So looking at the picture on the left, we see kind of the extent of it. Looking at the picture on the right is because again, I always forget to take pictures, is my kind of cobbled together version of what we did, which was separate the posterior leaflet going laterally or, to the left on the picture, debriding the calcium, reattaching everything along the line, that white line, having actually a fair amount of good supple leaflet to work with, and then reconstructing it with cords to pull everything back down. Now, this definitely is a more advanced repair, but it is absolutely possible with the right experience. Now, for the sort of cardiology side, I would say is, the temptation, and we're going to touch on this a little bit later, the temptation may be, not always, but might be to say, well, there's this MAC, there's this bad MR, maybe the patient's not quite so symptomatic. Maybe we just wait because we know they're going to get a replacement and we don't want to mess with that. And I would say, I would still send these type of patients pretty early because as you can see, you can expect a pretty good result if you know how to handle this type of a situation. So let's look at what happened here with that strategy. And again, all these should start playing on their own, at least the middle one. There we go, we're getting there. But you can see we've got a nice region of coaptation from the picture in the middle. We've got minimal leaking, we've got really good leaflet motion, and we have an unobstructed LVOT. So this is kind of pretty much as good of a result as you would hope. Now, from our perspective on the surgery side, we start to think, okay, well, it doesn't always look like this the first effort after a really complicated repair. This is a bit of a different situation I'm going to show you, but we also have to think, know when to go back. So if instead your echo afterwards looks something like this, a definite revision is necessary. And actually, in this case, some simple unification stitches at the commissural level and at the P2 to P3 level fixed this completely. It was just a little bit of excess tissue mobility that needed to be addressed. So going back to that, we know residual MR predicts long-term failure of not only failure of valve repair, but poor survival long-term. So if you have that patient, again, that maybe they had a repair several years ago, and we're thinking about, should we do something or should we wait? You know that with this recurrence, we know we're putting them at a disadvantage year the further we go out. So again, don't hesitate to refer these people, whether it's for the more interventional approach or for a reoperative surgical approach. We know that we want these people to be seen and to be managed. And looking at this, again, a really large cohort of patients this was from the Mayo Clinic, we know that even residual mild MR in the operating room can predict full sort of fulminant MR recurrence. And just to sprinkle a little of this towards the TEER community, we know that an annuloplasty is very, very protective against recurrent MR. So not the focus of my talk, but certainly something to think about. So looking back at that second case, this was simply a second run success where we've now fixed this problem. So another common question I often get is, well, what about the elderly? Or what about, the comorbid? Should we just replace this valve? Well, looking specifically at the elderly, we still look to see that there are some pretty clear disadvantages to mitral valve replacement. Now, even though this was from a very, very large national UK cohort that we sourced this data from, the problem is obviously is that, well, is mitral valve repair better than replacement outright, or is mitral valve repair just better because you're able to repair the valve in an 80-year-old versus someone that has an unrepairable valve is naturally going to do worse? Yeah, there's a bit of that. But we seem to see in a lot of these studies, again, this is a similar region here, we're seeing that repair seems to do better in survival. Mitral replacement seems to be a predictor of mortality. And when you meta-analyze it, repair seems to be coming out on top. Now, again, the caveat is, if you can repair it, you should repair it. But so take home here, if you can repair, it's always favored. You want a quality repair with less than mild MR. That's more the surgical side of it, obviously. And what we all have to remember is a good replacement is always better than a just okay repair, because we know a just okay repair is going to ultimately fail long term. And that, sometimes doesn't even get to long term. The sort of residual, maybe not quite mild, maybe not quite moderate, they often come back within the first 5 years. So moving on to another common scenario that we see here is multivalve and root endocarditis. So by looking at this, we can see this is pretty nasty. There's vegetations and also annular destruction at the level sort of posteriorly on the aortic valve side. We also see a vegetation at the base of the anterior mitral valve leaflet, which is a bit concerning, as you might say. And we have pretty bad aortic insufficiency. Now, again, I have to apologize in advance because I'm not great at taking pictures, so we're going to have to kind of fudge it a little bit. But here's another angle where you really see that mitral valve side lesion. And even though there's no frank fistulization right now, you're certainly concerned about it. And why isn't the 3D going? Okay, maybe if I just kind of scroll the 3D, there we go. You can see that there's a pretty nasty vegetation up near the lateral commissure. Oh, stop again. Come on, man. There we go. That's a good view of it. So root abscess, severe AI, lateral mitral valve lesion. Again, it's kind of the same approach. Repair or replace, can or should this even be repaired? Aortic, mitral, or both. We're going to talk a little bit about some advanced considerations and some timing. And I think this is where it's most relevant on the cardiac surgery and cardiology sort of heart team side of things, because timing is one of those things that can still be somewhat controversial. Where I think it's probably few of us on this call would disagree, saying that you want to get this person to the operating room pretty quick. You don't want to let antibiotics run their course, especially considering the severe AI. You'd be surprised how often in more advanced, fairly clear-cut scenarios, you see people kind of waiting, and I'm talking about left-sided endocarditis, where perhaps we should be expediting this along because patients, maybe they're not clinically all that sick and they seem to be tolerating it, but these patients can really kind of waste away. So looking again at the current guidelines, these are from the AATS, but again, sort of in concert with the American Heart Association as well. So really, we're looking at surgery, during the hospitalization, forget about the completion of a course of antibiotics in patients that have heart failure, or if they have Staph aureus fungal, other highly resistant or highly aggressive organisms. And certainly if you're starting to get heart block abscesses, these very destructive lesions, you really have to get on top of it. So there's really no points for waiting here. Really, when should you have the operation? So forget about the surgery indication. When should you have it? Once an indication is established, get after it. That's kind of the philosophy that I've been raised in. Now, obviously, there are nuances and special circumstances, but you really want to try and get after these right away. Unfortunately, sometimes we are held back a little bit by neurologic deficits or frank cerebrovascular events. And sometimes you just have to kind of pull the trigger and get the operation done and hope for the best. So looking at native valve endocarditis, again, for invasive and destructive, what do we do about it for invasive and destructive lesions and all that? Then it might be beneficial to not just patch and valve replace. We might have to think a full root, or we might have to think more of a total tissue-based solution. We're going to come back to that picture at the start, and you can see there's really no option for anything other than a tissue-based solution. When you do have to replace it, everything's pretty reasonable. Obviously, the risk of cerebral bleeding in that is a consideration. You don't want to absolutely have to put someone on anticoagulation because of a mechanical valve when you're in the context of a previous CVA or bleed, but it is a consideration otherwise. And it may be preferable to use tissue over a valved conduit, or even like a Bentall type procedure when there's a lot of annular destruction, just because there's not a lot to hold everything in place, as we're going to see in a minute. On the mitral valve side, we've talked a lot about the root side and everything. On the mitral valve side, if you have limiting lesions, or limited lesions, I should say, it's not always a bad option to be able to excise and patch or reconstruct. The problem with mitral endocarditis is that often it's not on the background of degenerative disease. So it's not like you have a lot of tissue to work with. And it's unclear whether some of these really advanced patch-based repair strategies are as effective. That, again, we're getting a little beyond the scope, and I don't want to get too in the weeds on that, but if anyone has a personal interest in some of these more weird and wonderful repair strategies, I could probably do a whole, for mitral valve in endocarditis, I could probably do a whole talk on that. But so thinking about the question, how bad is too bad? Well, on the left, you see the mitral valve, and that basically whole posterior leaflet is giant goober. So that is unlikely you're going to get a really good repair strategy. You kind of can't reconstruct the whole posterior leaflet with patch. You can try, but how well it's going to function long-term, I think, is going to be up for debate. The aortic root picture, and yes, that is an aortic root, on the right-hand side here is completely annihilated. And we're seeing here not only a complete absence of real annulus, all we're seeing is LVOT, but you're seeing where we've actually had to incise down and repair a fairly large Gerbodi defect. And that's the circle at the very bottom. The black circle at the very bottom middle of the screen is that Gerbodi defect pre-reconstruction. The circle in the middle is LVOT. So really the only way you can fix this is with a homograph. And the question then becomes is, well, what do you sew it to for those surgeons in the audience? And you sew it to whatever meat is available. The good thing about the homograft is that it's very, very hemostatic, and running it into place and having it really just kind of sucks in and seals, although that is a very difficult and technically challenging operation. So what are the advanced strategies? I mentioned the aortic root homograft. The benefit there is they come with a lot of extra tissue that you can use to your advantage. There's anterior mitral leaflet, there's dome of the left atrium, and there's a lot of aortic root muscle. So if you have to fill a pretty big tissue defect, this is a really nice option. And there are even some really advanced that I have not undertaken personally, but more advanced strategies where you can use that anterior leaflet to replace most of the anterior leaflet of the mitral valve as required. There is the Ross procedure. Let's not forget, I personally don't do this procedure, but in limited cases of endocarditis, it can be quite beneficial, especially on the background of an abnormal aortic valve to begin with, you know, the sort of the aortic stenosis patient, that kind of thing. However, with extensive tissue destruction, you can't harvest enough extra pulmonary autograft in many cases to deal with some of that tissue. So even though it is possible, it's perhaps not quite as applicable as the homograft in really, really bad cases. And then, you know I've cited the picture, which is a radiation case, but let's just pretend it's still endocarditis. The commando procedure, where in fact you replace the whole mitral and aortic valve complex on block, including the aortomitral curtain. So these are kind of those advanced strategies that sometimes we have to be prepared for, because you want to get all the tissue out and you want to get everything dealt with going forward. So again, what's the evidence for this? Some of it's not great, and a lot of it's observational, but it's sort of what we're stuck with. So durability of the homograft, you know, they do well, but a not insignificant portion, you know, up to you know, we're in that 30 to 40% range, you're having severe AI at that 12 to 15 years. So we do know homografts do degenerate, and they're often kind of nasty when they degenerate. So patients with homografts really need that close observation year to year. Ross procedure can be very effective in endocarditis. And in fact, it seems to be very, very resistant to infection, more so even in some cases than the homograft side. Now, just to muddy the waters a little bit more, you know, what about homograft versus conventional prosthetic? And again, this is a locally driven study, even more so than the last one I showed, from right here at St. Michael's primarily. So what we see here is with survival, we don't really see a clear-cut difference. And with reoperation, we don't quite see a clear-cut difference. So this kind of brings up the question, well, when or should you do one or the more advanced ones? And really it becomes when you absolutely have to. Because generally speaking, if you have an option where you can patch and replace, conventional management, it looks to be just as good. The problem is that you don't always have an option to just patch and replace. So what happened with this patient? Again, because I forget to take pictures, this is what the debridement looked like. So on the right-hand side, where we have the aortic root opened, that was all debrided, and actually a very clean, smooth abscess cavity was found, but we did, in the course of debriding it, break through into the anterior mitral leaflet. So we were left with this hole. So thankfully, a patch repair and annuloplasty with a patch repair of a second patch repair of the aortic root, with then the aortic valve placed over it, worked excellent and provided a very good result. And this is what we see at the end. So even with a pretty advanced lesion, just patch and replace can work just fine. But again, this patient, even though it was pretty nasty when we started, this patient was found pretty early taken to surgery very early, and recovered actually quite well. So things to remember here, endocarditis covers a wide spectrum, generally reasonable for a conventional approach, but major tissue deficits and destruction might need an advanced strategy for success. I think the important thing too that I did forget to put here is that we really want to see these patients as soon as they arrive. It's not always possible, but we want to be aggressive with these patients for the best outcomes. And the last thing I want to talk about here is type A dissection. So this actually is a fairly young patient that you're going to see has pretty clear, I'm just playing my video here, everyone should see it well, pretty clear aortic dissection. But if we kind of stop things initially, the first thing I want to draw the attention to is that this globally doesn't look all that big, but when we measure it, the root was just over 5 centimeters. And the ascending was kind of in the not quite so bad, but getting their range as well. So this guy had the kind of root phenotype that when you see it before surgery or before complication has the kind of tulip bulb appearance that I refer to it as. And this patient actually was known, but not yet referred to surgery. And unfortunately, we saw him on an emergency basis. And we'll keep scrolling through here. Our tear is right here at the very distal ascending proximal arch. And the bonus for this fellow is that there's a subclavian, there's an anomalous vertebral, and then the left carotid, and then the innominate artery. So when thinking about this, especially if we're thinking about a more advanced strategy, this has to be taken into consideration. If you're going after the arch, you have to know that is there. So this is a type A or DeBakey 1 dissection with a root aneurysm, and it goes all the way down, went all the way down to his iliacs, but thankfully didn't cause any horrible malperfusion. Though he did have a little bit of belly pain, but there was really no signs of proper malperfusion. So again here, what's the extent of the operation? Address the root, address the arch. Very importantly, how are we going to perfuse the body and the brain? So again, we go right back to the guidelines here. So what do? Well, in patients that have, extensive destruction of the root or an aneurysm, valve conduit. But in patients who are stable, they're healthy, they're otherwise not, we're not really in extremis, and if there's appropriate experience, perhaps a valve sparing situation could be very could be ideal here, especially if they're young. And when we're looking at a flap that's extending through the arch into the descending aorta, doing an extended arch repair is not the worst case scenario, which is kind of the antegrade stenting or perhaps the kind of frozen elephant trunk approach. Now, these are progressively softer indications. It's a 2B recommendation. But with the appropriate experience, these are becoming increasingly more common, and places with a lot of aorta experience are having less and less of a threshold for a valve sparing or an extended arch or both at the same time. I think for the surgeons, it's very important to always have a perfusion strategy. Antegrade and even retrograde cerebral perfusion through the venous side have both been shown to be safe and effective, and I don't know that one has actually been shown to be superior. Axillary, femoral, direct aortic, all are options. You want to address limb malperfusion. And our perfusion lines with all the stopcocks and Ys and things can be can be very complicated, but they can be created such that you perfuse whatever bed you need to. So this is what I know as the RAC, which stands for Roselli antegrade cerebral protection. And in this is a setup for an axillary graft, which then has a separate line that goes up with the Pruitt vascular balloon to perfuse the left carotid as well for a bilateral cerebral perfusion strategy. You could easily splice in another stopcock, another line, all sorts of things. In fact, I had a dissection just recently here that I did in concert with Dr. Wheatcroft, where we sent a separate line all the way down to an occluded or a femoral artery that was occluded by the dynamic dissection flap. So there's a lot of customizability here, but you want to make sure all the major vascular beds that you need to perfuse, most importantly, the brain, are perfused. So again, well, what's the evidence here? Well, what's the evidence for, in this patient, just doing a hemiarch versus an extended repair? Well, they seem to have equivalent mortality. They seem to have equivalent permanent neurologic deficits. This is a study driven by us here in Toronto, but on behalf of the Canadian Thoracic Aortic Collaborative. But the composite adverse outcome endpoint was higher, but also malperfusion and resolution and remodeling all favored extended arch repair. So it's something to think about. But again, it's very expertise driven. I have not yet had the pleasure of doing an extended arch here yet, although it's something that I've always got my eyes open on. Where I came from previously, very low threshold to do a frozen elephant trunk. And similarly, I know down the street, very low threshold to do a frozen elephant trunk in these cases. So what do I do? This is my past lives series of our frozen elephant trunk. And we use this. It is very reproducible, very customizable, and very easy to learn, where we deploy a frozen elephant trunk stent antegrade. We fenestrate it as a sort of hybrid approach and place a stent in the left subclavian. And from there, you can either stent anomalous vessels or other vessels. You can reimplant. You can use multiple anastomoses. You can debranch this arch however you feel necessary. So, and it's importantly, it's fast and it's quite safe. You know, looking at mortality in an acute aortic dissection of 8% is well under the IRAD or international registry reported rate of around 18%. And in fact, the mortality rate in both arms of the previously mentioned study happened to sit right around that 18 to 20% range. So in fact, this can be very, very effective in all cases. So what did this patient have? This was a very complex repair, but thankfully we had the support to do it. And there I have no doubt we could pull the same off right here at St. Michael's Hospital. And it was axillary cannulation with an extra balloon for a bilateral cerebral protection strategy. It was a single anastomosis, multiple stent, Be Safer, which is what that previous one was called, branched single anastomosis frozen elephant trunk repair. We used the following: a Gore C-tag, and we used 3 Viabond stents, including one to the anomalous vertebral artery. And you might think 6 millimeters by 2.5 into an anomalous vert, that is going to go down immediately. And in fact, it's been open until last follow-up. And we did a David reimplantation with a size 30 gel weave Valsalva graft. And compared to the previous films, where we have sort of a total reconstructive strategy here. Oh, not supposed to do that. Sorry. What we can see is a nice normal looking aortic root up into what looks to be a conventional hemiarch anastomosis, and then left carotid, left vertebral, or anomalous left vert and left subclavian, all stented, with again minimal, if any, endoleak around the more distal part of the prosthetic until we get to the extra part of the aorta. I'll just cycle through on the axial view here as well. Now, you might be asking yourself, why on earth would you go through this trouble? Because the consideration then becomes, what happens next for this fellow? And in fact, this was his 3-month CT scan, not just before getting out of hospital. And in fact, even with the residual false lumen was degenerating at a relatively rapid rate. So this guy needs something else done. And so it's way easier to go in from an endovascular, or even if we have to do a thoracoabdominal approach, what you have at this stage, up at the distal end of the stent, what you have is a platform for reintervention. So much like we're starting to always think about what's next in an aortic valve patient, in a TAVI patient, set ourselves up for success and for lifetime management. More and more, I think we have to start thinking about that with the aorta as well. Because coming in to then do another operation to, say, deal with a degenerating arch, and then perhaps a third stage, which is potentially a TVAR or a thoracoabdominal approach, are just less and less ideal, rather than having a platform for a fairly straightforward intervention. And this patient actually ended up having his stent graft extended without any major concerns, and has had some pretty good favorable remodeling since. But this is where there's some really, really good and Canadian-driven really good future research. So this is the Head Start trial that's actively recruiting. In Toronto, I believe only the general is involved at this stage, because the devices and the specific extended arch are sort of device specific, although it is going to be opening up hopefully in the next year or so. But this is going to really hopefully answer that question of when should you just, if it's sort of both equivalent, like, to be fair, this patient was, is it better to do an extended arch or to do a hemi-arch? I think we're probably going to see mortalities probably about the same, unless you're forced to do one versus another. But I think we're going to see favorable remodeling. We're going to see favorable future interventions, and future sort of morbidity be the major benefit factor, but time's going to tell. So again, what are the take-home messages here? A successful operation in a living patient remains the primary goal here, but we are becoming more and more aggressive, and it's more and more likely that dissection patients are going to be having these extensive and more aggressive repairs. Frozen elephant trunks being increasingly adopted, increasingly recognized, and typical centers of excellence have a very low threshold for a valve preserving strategy or an arch related, arch and descending aorta related strategy. Regardless of what you do, we got to protect the brain. The era of cool and sew as fast as you can is really outdated at this stage, especially when we know how well antegrade even retrograde cerebral protection works. Although for a lot of this, we do need the ongoing research to really better define what the best course of action is. Now, again, this won't be terribly controversial on the cardiology side. In the case of dissection, they're coming to us pretty well as an emergency, unless they're truly a chronic, incidentally found, etc. situation, which, to be honest, are few and far between. But I think the take-home point with this case of this patient was, if that aorta is getting anywhere in that 4.5 to 5 range, it's time to give us a call, because ideally, and unfortunately, the patient's cardiologist sort of met with us to talk with the family afterwards, and was, I mean, he was sick. He felt sick that he hadn't quite talked to us yet. He was like, it was kind of just getting there. I didn't know if it was big enough. It's always big enough to ask our opinion, is I guess the take home for the cardiology side and the imaging side. It's always big enough to ask an opinion. I'd like to leave you with one of the best quotes from a former colleague of mine, as by way of closing here, and that is, at its highest level, cardiac surgery must be performed among friends. I'm thankful now to be part of 2 very close friend groups in my career thus far, and thank you guys so much. This doesn't just extend to the surgeons, but the cardiologists and the whole team, from the person that cleans the floors to the person who's signing the orders. So thank you very much for listening. It's been my pleasure to give this talk, and if there's any questions or any concerns, or if anyone completely disagrees, I'd love to hear.
That's great. That's great. Thanks very much, Dr. Burns, for sharing with us these interesting cases, and a very nice summary, actually, of some of the guideline recommendations with respect to management. We'll open up this actually for questions for Dr. Burns. Okay, so I think Anassa has his hands up.
Sorry, Daniel, thank you so much for this Great overview and interesting cases. Just wanted to ask a couple of questions. The first is there's, as you know, you're part of the structural team, and there's an evolution in the transcatheter approach. And I just wanted to know your thoughts on, when we deal with these patients, whether at least for mature procedures such as TAVI or clips, whether it's going to be like transcatheter first, surgery later, or surgery first and transcatheter later. We go through this in coronary disease. Sometimes people get PCI early on and surgery later, or other people the opposite. And the other question I have is any updates on surgical techniques on VSD or like post-infarct VSD, because these are again a challenging group of patients that tend to be sick, and there is no great solution for these patients.
For sure. Yeah. So, there's a million and one scenarios where you can talk about getting aggressive, and I kind of picked the three that live where I live. TAVI, that's a great question, because that's super active part of the discussion, and as you well know, that's something we sometimes go round and round with. I think, like anything, jumping into one versus another, you always have to. I don't know that there's necessarily the right one first. But it's going to depend on so many factors, age, comorbidities, life expectancy, but also like the anatomy, all the imaging, the dimensions, the geometry. So I always think, like, look, some patients are just like, I do not want heart surgery, period, and blah, blah, blah. And it's like, well, I may not agree with that decision, but it is approved for a low risk cohort, and we sort of know what that comes with. Aortic valve replacement after TAVI is not nearly as bad as it used to be, so to speak, but it is device dependent. I much prefer taking out a sapien than I do like taking out a core valve. But it's still not usually the end of the world, and sometimes you got to do a root, but like, what are you going to do? But I think honestly, for a patient that's refusing surgery that needs it, what are you going to do? You're going to say, no, we're not going to do it. You're going to go die. No, that's not the right thing. But I think the thinking about it means not necessarily thinking about what's next, but what's after next. So it was very common to be like, oh, well, this person's really young and healthy, and it doesn't really make sense to do TAVI now. But if we do surgery now, you're going to put in like a 27, and we're going to have enough room for a valve in valve, and then a TAVR in valve, and then that's going to be okay. But other ones where you think we might be a little bit hamstrung here if we need to do valve in valve in the future, or if we can put a TAVI in now and it's going to be fine, but like those coronaries aren't great, and maybe you need a root enlargement, whatever. So I don't think there's any specific right answer, but the important thing I think is the structure, and to really look at it 2 or 3 steps down the road when we're having those rounds discussions. And what I've loved is that the team essentially functions the same way that I did in my past life, where it's like no one has a problem being like, why don't we just operate? Or why don't you guys just operate, or vice versa? Everyone's pretty reasonable about really focusing on what's next. Now, the VSD side, those cases are brutal. I must say that's something I haven't done a lot of, because they went to sort of the specialist heart failure side. But I do know from being, again, adjacent with a lot of these, is that early institution of mechanical support can be a game changer. So the way this would typically work in Cleveland was this patient had come in rough shape. They'd get an Impella. They would get aggressive early mechanical support. They'd coast them and optimize them. And then with that assist device still in place, would do the operation so they can come off on support and avoid ECMO. Not that ECMO with or without not that ECMO with event can't be effective, but without that sort of forward support, they just don't seem to do as well. And also, we know operating in the early stage, as we all know, it's a rough situation.
Thank you so much.
Thank you. Yeah, I think Dr. Chow has a question.
No, sorry, just have to unmute. So Daniel, welcome to Canada. Just curious about your observation, the difference between practice of cardiac surgery in U.S. versus Canada.
The day-to-day really isn't all that different. I mean, having some of the more like, we'll call it administrative side, like dealing with OHIP and dealing with that is a bit irritating, but like the day-to-day practice, I don't find all that different. Where I do find it different is you are somewhat of a liability in Canada to the hospital, whereas you are in the sense that like the only way I can do stuff is if I use stuff and take up time and resources and everything. Whereas in the US, you are a generator. So, whatever fancy device, whatever thing you want, no problem, it's fine. You want to do a case at 2 a.m, it's fine. So the only real difference, I've said to many people, I've lumped things into 3 different boxes. It's a problem, and I just have to get used to it because it's a different system. It's a problem, and I have to get over it because I was spoiled, and it's a problem actually, and we have to deal with it. And thankfully, not many things are in that 3rd box. But honestly, I don't find the practice that much different.
It's good to hear. Thank you for sharing.
Thank you. So I guess, Dr. Burns, if I may ask, if I may ask 2 general kind of questions. So obviously, valve disease has come a long ways. I mean, when we go back at the guidelines back in 1998, actually, there were actually very few randomized control trial data, actually, in support actually of the recommendations. And now we have certainly seen a lot of, important trials that have really shaped our practice today. And when you discuss the observational data comparing mitral valve repair and replacement, you are careful in pointing out that this could be residual confounding with replacement only done when repair is actually not possible, despite adjustment for the known confounders. So I just wonder what your thoughts are. Like, do you think that we have the answer here, or do you think that we have to challenge, some of the current kind of dogmas and, keep pushing the envelope to do even more randomized control trials actually in cardiovascular surgery? And do you think that's actually realistic?
I think it depends. I think that you will have, with the evidence base right now, looking at, say, mitral repair versus replacement, not in extenuating circumstances, but for typical degenerative disease, your mitral valve prolapse, anterior leaflet, Barlow, whatever. I think you're going to have trouble finding equipoise for an RCT. There's just the evidence is and the sort of the baggage that goes along with it it's pretty clear from really big, high volume groups, registries, all that. So I think that one's probably never getting done. However, what we're seeing now is the standard of care versus, what's new is what's really coming along. And we see, there's now 1,000,001 TAVI ones, but also the looking at the mitral ones, the primary trial and the repair MR trial. Now both have their own pros and cons, but looking at mitral repair versus TEER for your so-called equivalent degenerative cases. And that's going to be very, very informative, I think. But I think for some of these, there's just, you can't trial everything. And when we're getting into the weeds, like the elderly and stuff like that, where there's 1,000,001 reasons why repair versus replace is not quite clear, you do your best to adjust for everything, and there's going to be some degree of selection bias. There's going to be some degree of residual confounding. But it still gives you a pretty good indication that if you can do some of these things, you probably should.
Perfect. That's great. And my second question, if I may, is also a bit of a general question and maybe philosophical, and that is, in cardiology, we have learned over the years that, less is more, sometimes with respect to antithrombotic therapy, and perhaps sometimes actually even with respect to revascularization in stable disease. And you also kind of show us some data comparing like extended arch versus hemi-arch actually for type A dissection. I guess maybe suggesting that less sometimes actually might be more. And, it's interesting also that the Head Start trial that you alluded to, actually, I think one of the interventional radiologists actually, did some work actually here in St. Michael's Hospital, actually, almost a decade ago. So I wonder if you have any comments actually about that. Do you think that, I think when you answer actually Dr. Child's question with respect to U.S. practice versus Canadian practice in general, I mean, sometimes, I guess maybe people are more aggressive actually south of the border. I wonder if you have any comments actually. Do you think that, at some point actually, maybe, obviously the title of your presentation today is being kind of more aggressive, but do you think that in some situations actually really less could be more?
Absolutely. Absolutely. So So the, again, it's kind of thinking, one of the things that perhaps I could have gotten across better with this presentation was more about you don't always have to, but I think knowing when you need to be and being sort of equipped to do it when you have to is beneficial. Certainly, you don't always have to. And there are times when you want to do a more, for any number of reasons, low EF, other illness, renal disease, that sort of thing. You want to do a quicker operation. You don't necessarily want to go after a complex reconstruction. I have two dissection cases right out of the gate where I was like, we are getting in and getting out of here. Unless that tear is smack dab in the middle of the arch, we're out of here. And it was a young woman in her 30s with Turner syndrome, where everything was short, everything was small, and it was just hard to do anything at all. And the other was a patient who had had a previous extrapleural left pneumonectomy, and the whole mediastinum was shifted. And there was just no room, no exposure for anything. So there are absolutely the cases where less is more. There's absolutely going to be that mitral valve where you're like, for some reason you don't want to be on bypass for a long time, and you're like, well, I could do this, but it's going to be a really complicated bileaflet. Like, yeah, I'm sure there are going to be those situations where it makes more sense to just say, forget this and replace it and just move things along. Absolutely. But that's where I think the real medicine happens. Like I've said for a long time, I think, you can have all the guidelines you want, but the real medicine happens in between.
Right.
And interestingly, practicing in the US was not this issue. Practicing in the UK was this issue, because they are like to the letter of the guidelines. Even if you're like, well, this is a really bad idea, or not a really bad, this is not optimal because of XYZ or something, or no, actually this drug is indicated, even though the guidelines haven't, they don't capture or whatever. It was actually more of a problem there, I found. But
right.
my view on that is absolutely there are the situations where more is more and where less is more. And the fine tuning and the nuances of the case and the working in between the indications and the guidelines is where I think the real medicine happens.
Right, absolutely. So nothing replaces good clinical judgment, right?
Exactly.
Absolutely.
100%.